So chronic lymphocytic leukemia, just really basically what is this disease about? Chronic means that it's a persistent or a prolonged clinical course. It's not, we have a difference within blood cancer. Some of them are very aggressive and they come upon the person quickly, they develop symptoms quickly, and they need treatment very quickly. Chronic lymphocytic leukemia is not usually like that. Most people develop their symptoms over time. They may not realize that they're ill. The symptoms can be very light in the beginning, and some people never develop really significant symptoms with their disease, all right? And it can persist over many, many years. For some patients, though, they do get diagnosed and they are symptomatic because they didn't realize they've been sick, so by the time they get to a doctor, their disease is a little bit more advanced. Lymphocytic just refers to the fact that it's a type of blood cell called a lymphocyte that is affected in CLL. And then when we get to leukemia, leukemia just means white blood, so it's something that's happening in a white blood cell, okay? So some people get confused. I know that people ask me all the time because I work for the Lymphoma Coalition, if CLL is a leukemia, why do you at the Lymphoma Coalition work with CLL? It's a little bit confusing, but what has really happened with this disease is that it was named a really long time ago. And most of the disease, if you're looking when you're diagnosed with chronic lymphocytic leukemia, most of the cancer will be in the circulating blood, right? Which is very traditionally a leukemia. But if you look at the cells of CLL under a microscope, and you look at the cells of SLL or small lymphocytic lymphoma, they look the same. So what is happening is it's the same disease that grows in the body in different places. With SLL, when it's diagnosed that way, you usually see the disease more in the lymphatic system like you would with a lymphoma. So what the World Health Organization did a few years ago is they classified both under the lymphoma area because the disease actually acts more like a lymphoma even if it appears in the circulating blood. All right, so you'll definitely hear in different places that CLL is referred to both as a leukemia and a lymphoma, and neither is completely wrong, right? So that's why.
And I like that because we get research dollars to do the research for both leukemia and lymphoma, and we can belong to all the leukemia and lymphoma organizations. So it's an advantage to have a dual diagnosis. Yeah.
There you go. Do you feel special? Yes. All right. The blood cells that we're working with here, they're produced in the bone marrow. All you really need to know here is just an example of the bone marrow to understand what is happening inside. It's a spongy kind of area right in the middle of the bone. There's stem cells that form different characteristics of the blood, and that's where the action is happening. There's other things that are happening in the bone marrow, but what's kind of important when we look into this is when the leukemia cells start to develop, they can start to crowd out what's happening there. And there's specifically is the white blood cells that are produced. But if we look at this diagram, so you see those blood stem cells at the top, and we follow that trail down on the right-hand side. Those are all the different types of white blood cells that can be produced out of these cells. What we're concerned with here is called the B lymphocytes. And that's just a certain type of white blood cell that is actually plays a critical part in your immune system, right? So if your immune system is going to function properly, your B cells are one of the cells that is going to actually help identify the things that come into your body that shouldn't be there. So it helps identify viruses or bacteria or other foreign particles that shouldn't be there so that the rest of the immune system can kill them. Now, in some cases, B lymphocytes also actually actively kill something or get rid of something that's not there, but usually they're more of an identifier. But when they're not working properly, which is what happens with cancer cells, then your immune system can't function properly. Okay, which is why when you're talking to your patients and they start talking about what's happening within their body and how they're feeling, a lot of it is related to their immune system not functioning well. All right. What can also happen then with the growth of those cancer cells is that they're crowding out the other blood cells, And so their other blood cells will often see a change from normal. So you'll often have a reduced number of red blood cells, so you're not carrying oxygen as well, for instance. You'll see a reduced number of platelet cells, which means that you can't, your body isn't clotting properly. Those things are happening because the white blood cells are kind of growing too fast and taking up the room in the blood. All right. So the lymphocytes, just showing here what the lymphatic system looks like. This is just a diagram of a portion of them. It's not like everything only happens on the left side of your body. They're all over the body. They're also not really green. So if you ever looked really inside a person, it's just to help you understand how this is working. The lymphatic system is in some ways like your circulatory system or your blood system, in that it is a series of vessels that go through your body. Not quite as extensive as your circulatory system, but it's there. What happens with these vessels is they connect a series of lymph nodes. You can feel most of your lymph nodes in your neck, sometimes when you're ill, or under your arms, and sometimes in your groin. Those you can feel. But you can also have lymph nodes. You do have lymph nodes in your chest, your abdomen, and other areas of your body, right? But usually if people are feeling the lymph nodes due to an illness, it's usually they're going to feel them here or in their groin. The lymph nodes, this whole process, the lymph nodes are helping catch, sort of, in a way, catch the stuff that has made it into your lymphatic system that shouldn't be there, right? So it's filtering what's going through your lymphatic system and helping getting rid of those, the viruses, the bacteria, anything that's not supposed to be there. So when you're sick normally, so if you have a cold or the flu, those are going to get big anyways, right? They're supposed to get big when you're sick. That's perfectly normal. But then they're supposed to resolve, so they're supposed to go down. And often when you have a cold or the flu and you feel like your lymph nodes are big, they're also tender to the touch, right? With our cancer patients, they're not always sore, right? So often when you have cancer, those lymph nodes get big, they stay big, but they don't hurt. They're just, they may cause discomfort because they're big and they're bulky and they're getting in the way and you don't like the way you look. You can also have some other symptoms related to how big those lymph nodes have gotten, especially if they're in your chest or your stomach. You may have, you may get full too fast, for instance. So you can have symptoms related to how big they are, but they're not necessarily going to hurt, right? And they usually will persist, so they're going to stay swollen. What we need to know, though, with this is because those lymph nodes and the lymphocytes are circulating through your lymphatic system. You know I'm using that term lymph a lot. The cancer can spread anywhere, right? So it's in your circulatory blood, it's in your lymphatic system. So we're dealing with a cancer that's going to be throughout the body for a patient. All right. They may have lymph nodes or symptoms of the disease in a certain area, but it doesn't mean that the cancer can't flow. So you'll hear this term global B-cells or global lymphocyte. So what does a clonal lymphocyte actually mean? All it means is usually there is one cell that's gone rogue. So it all started with one cell that has become cancerous, whether that's through some kind of a genetic mutation that can be caused by lots of different things, right? And then it expands within the body. Now, depending on the size or how many of those clonal B cells there are that have developed in the system, you may or may not be diagnosed with CLL. So you can have a number of these cells that look like CLL cells in your blood, but if you don't have enough of them, you are not going to be diagnosed with CLL. We will talk about this a little bit more, but the number that they use is arbitrary. It's a group of doctors that sat together and said, what do you think we should do with this? We know some people have these cells, but they never develop the characteristics of the disease, and it doesn't progress. What does that mean? How do we decide who's actually going to get sicker and who's not? And they picked a number. Now, those doctors that did that will admit to you that it's not a perfect system. And we expect over time that this will be perfected with more different tests, and as they figure out more about the disease, we'll get better at this. But it is really a random number. It's a pretty good safe bet. I mean, it's not like they just sat there and, over a beer and said, what do you think? I think 5,000 is good. Okay. I mean, there is some science behind it, but it just means that it's not perfect science. All right.
Can I just add that that's the monoclonal B-cell lymphocytosis?
Yes, it is.
And the difficulty from an advocacy point of view is that patients that are diagnosed with this condition think that they're going to get CLL and they may never form CLL. And they can live all their lives. So they're being told that they have a pre-cancer and that they feel that it is going to turn into a cancer. So from an advocacy point of view, it's a difficulty, So it would be wonderful to know that we know will then patients develop CLL or not? So,
Yes, yeah. And we'll talk about this a little bit more through this presentation, but there are a lot of unanswered questions with CLL, and one of those is who is really going to get sick and who's not.
And the other flip side to this is a lot of people are diagnosed with CLL, and a significant percentage of those, depending on who you read, 15-20% of those people will never need treatment and have the same life expectancy as someone who isn't diagnosed with CLL. So we've now given them a diagnosis of cancer. They're going to live their whole life with this cancer. It can affect their ability to get a job, to get insurance, everything, and they have a normal life expectancy. So wouldn't it be better, instead of saying it's 5,000 your cancer, 4,900 you don't have cancer, wouldn't it be better if we had a better way to do this? And we're actually working, that's one of the things that we're working at an advocacy level, is to change what the goal line is, in terms of the diagnosis, because it hurts on both sides.
Do you think there is a chance that they will be able to find a biological difference between CLL cells and just
The monoclonal B-cell lymphocytosis?
yeah.
Yes, I think they're working on looking at that. And I think the division may not be between the monoclonal B-cell lymphocytosis, it might be between whose CLL progresses and whose disease doesn't progress. And they're working very hard on those kinds of things, and they've got some of it figured out, but a lot they don't. But that's a big area of research, especially at the Mayo Clinic in Rochester, New York, or Rochester, Minnesota is doing a lot of work on that.
Yeah. So seriously, all you need, if anyone talks about a clonal cell, they're just talking about that original cell that triggered the CLL. All right, plain and simple.
Yeah.
Smudge cells, this is just showing what the damaged cells look like if you're looking under a microscope. That's all that's referring to, right? So they can easily look. Obviously, CLL can be diagnosed with a blood sample, unlike other types of lymphoma where you need a biopsy. This you can look at a sample under the blood. It doesn't mean that other testing shouldn't be done, but that's how they can diagnose. And so this is just what it'll look like, and it's just pointing out to you that's how they tell that this is CLL. All right. So just really quickly, CLL is most commonly diagnosed during a routine physical exam. Most patients come in and they don't have any symptoms of their disease or any symptoms that they recognize are from their disease. If you look at most of the primary symptoms of CLL for our patients, the number one thing is fatigue. I don't know about the rest of you, I'm tired today. So, we can blame fatigue on lots of different things, and so you may not recognize that as a symptom of your cancer. Even if you start to get enlarged lymph nodes, you can blame that at least for a while on the fact, like, I must just have an infection somewhere, I must have a cold. You may not notice, and especially then if you're enlarged lymph nodes or in your chest cavity or in your stomach, you can't feel those, so you wouldn't know. You may have other symptoms like your stomach's not quite happy, or you just feel full. Even if you lose weight, as a symptom of your CLL, which does happen, it's losing weight over time. So we're looking at those symptoms developing over a 6-month period. And over 6 months, you may not really notice depending on the weight change that you're experiencing, for instance, right? And so it's really important for our patients, just remember when you're working with our patients that this may have been a really big shock for them. They went in for just their general annual physical exam thinking that they're okay, I'm a little tired, but life is good, and they learn very shortly afterwards that they have a cancer. What's also difficult then with CLL diagnosis is, of course, that the option to treat initially is watch and wait for many patients, right? So if then you have cancer, but we're not going to do anything about it, it's a really hard thing for patients to adapt to. So we do have sessions dedicated to this kind of phenomena within the CLL Horizons meeting for this purpose, that it remains a big issue for patients to cope and work with. All right. We just talked really quickly about the 5,000 clonal B lymphocytes, so really they do count them. They're looking at the numbers in any sample and doing a multiplication out so they can understand your diagnosis. And again, now we know that that's a little bit questionable about how they decide that, but we're working on perfecting that so we can better help our patients understand who's going to get sick and who may not. So even though they can do a diagnosis with a blood test, it does require a very specific test. They use flow cytometry. It's just looking at the surface of those cells. So those cancer cells themselves, all of your cells have different proteins on the surface. What they do, they have different functions within the body. You don't really need to understand the specifics of them. If you want to know, you can come ask Brian and I, and we can bore you to tears with some information on that. But there are certain ones that you are going to see on a CLL cell. So if you're looking, these are below are the classic markers for CLL. CD just stands for clusters of differentiation. You don't really have to know what that means. All you need to know is that doctors may refer to CD5, CD19, CD20, and CD23. Those come into play with certain treatments because they may target some of these, right? As well as them being an indicator of something that we see all the time on CLL cells. Sometimes they're also targets for treatments, which is why you may hear the doctors talking about them more. All right. Anything else you want to add to that?
The only thing I'd add is that it's unusual. So these were B cells, we learned, and B cells make antibodies, and T cells are the soldiers, the fighters themselves, cellular. CD5 is not supposed to be found on B cells. It's found on T cells. So that's what makes these unusual, and that's what stands out. CD19, CD20, CD23 are found on normal B cells. So sometimes when we target CD19 or CD20 with therapies, we're wiping out all our normal B cells. If we target CD5, we wipe out all our B cells and T cells, which is not a good thing. But that's what makes this unusual, and that's why it's easy to pick out that it's CLL, because the CD5 marker is positive. It shouldn't be.
All right. So this is just a reiteration of what I was talking about with the SLL versus CLL. This is really confusing for patients. So I hover on a bunch of online boards, right? So different forums, different Facebook groups, all kinds of different things. Patients know I'm there. When I register, I tell them who I am and what I do and why I want to participate in their forums. But there are always, this topic comes up and up and up for patients. Do I have SLL? Do I have CLL? What's the difference? Why did one doctor tell me I have both CLL and SLL? It creates a lot of confusion. So when we try to explain, this really is just where they're seeing the disease, right? If the disease looks the same under a microscope, it's just where it's appearing. If it's really in your lymphatic system and you have a lot of swollen lymph nodes, and that's where the doctor is really seeing the activity of the disease, he's going to give you a diagnosis, or she will give you a diagnosis of SLL. But if it's mainly in the peripheral blood, you're going to get a diagnosis usually of CLL. What we really stress with the patients is it doesn't matter when it comes to treatment. So your treatment will be exactly the same when you get to that place. even if it's watch and wait, at that beginning phase, it's exactly the same. They're treated identically. It's just a difference in where the disease appears. And if you are diagnosed originally with SLL, and as your disease progresses, you may then get a diagnosis of CLL. It doesn't mean that your disease is really worse. It just means it's traveling around your body. And it's still, your treatment course is not going to change, and your treatment, the indicators for treatment are not going to change. But it is really confusing. I know that doctors have done a lot of videos, and we'll refer people all the time to these different videos done by all these specialists that try to explain the difference between CLL and SLL, and it generates even more questions then from patients who are just confused. So really, we go back to really focusing on the fact that your treatment will be the same, the course of the disease, the expectations of what we might see for you don't change regardless of whether you get the SLL or the CLL diagnosis. Hi, Leah.
As I was very lucky to have SLL and CLL, and as I've worked a lot in research, something here doesn't sound very good to my ear, because all the time we try to be more and more specific, finer, to find different kinds of CLLs, and suddenly we take two conditions, not illnesses, but two conditions, and so it's the same and we treat it the same. Something here doesn't sound good to me. Something here is just like we jump something, and it's easier for us to say that SLL and CLL are the same, we treat the same, maybe we get good results, probably we do, otherwise we wouldn't do it. But something here is missing, and I think maybe there is no interest to do it or something. But I don't believe that it is just the same. There is a difference, and there should be a difference of thinking about it at least.
I think what happened here is really that our diagnostic testing and our way that we can look at the intricacies of a cell under a microscope have actually improved significantly over time. So when we first came up with the names of small lymphocytic lymphoma and chronic lymphocytic leukemia, it was based on testing that wasn't as good, right? So they couldn't see the same things that they can now. So they were going with where the disease presented in the body. It was later when the testing got really good and we can get into the mechanism of the actual cancer cell that they could see under a microscope, we can't see any difference. You're right, it could be right now. And that as we get even better with diagnostic and microscopic analysis, that we could see a difference. But so I think that progression happened from that reason. It wasn't intended to misrepresent the disease initially. It was because of limited ability to look at this. We gave them different names because they appeared in the body in different places. So only later we got this information. We look at it and we're going, okay, they look the same. And we treat them exactly the same, and this is what's working.
Can I add a little bit, Brian?
Everybody wants to talk on this topic. It's very...
See what you started. You know, I fully agree with you. It causes confusion, CLL, SLL, and I do see that in the patient community. An SLL patient doesn't think that they have CLL. So all this, but the problem with CLL when you take it a step further and the understanding of the disease is that CLL itself is many diseases. There's many different, it's that word heterogenesis, am I saying that word right?
Yeah.
Heterogeneity,
yeah. So, and what happens is that a CLL patient has a profile and no two CLL patients are the same, which you'll hear this so often. So it's not just, SLL and CLL is just one part of it, but we can't fix the confusion throughout, and especially with all the breakthroughs and the new novel therapies and the targets, that a patient needs to know what profile of disease they have, which we'll get on to later on. But so it's very hard to get away from the fact that it's different diseases, because all throughout CLL it's different for every patient, and the patient needs to know. Am I explaining that right?
Yeah. So we'll get Brian will actually talk a little bit more about some of the differences we see within the CLL patients in terms of their molecular profiles and stuff, so that you can understand a little bit better what is going on with this. Yeah.
There are some markers that are different between SLL and CLL, and they've looked at that, but they're not targetable or clinically significant in terms
not
of the
significant.
management. But there are some differences in terms of how the cells hone, and the SLL cells like to live in nodes more and stuff. But it makes no difference at this point in terms of how we treat them. And it has evolved. There used to be something called T-cell CLL, which now is considered a different disease, so it has evolved. What has really changed is what Michael talked about. Where we've really gone is not the division between SLL and CLL, but what flavor, what type, what bucket of CLL are you in, because it's a very, if you know one CLL patient, you know one CLL patient, because everybody gets treated differently, everybody has a different disease. Like I said, some people never need treatment, some people, the day they're diagnosed, they're rushed into hospital for treatment. I mean, that's rare, but there's this whole spectrum of disease. That's where all the research is going, not dividing SLL and CLL. It's looking inside and seeing what's driving the cell, what mutations are there, and we'll spend a lot of time on that later.
All right, the staging system for CLL, there's two systems that doctors may refer to depending on where they happen to live in the world as we go through this conference. It's not just, I know we have American here, this is used in Canada and other places as well, but the RISE system, by the way, these are named after doctors because it's good to be a doctor, you get your name in perpetuity. Yeah. You get to be famous and have your name attached to everything for many, many, many years. Canty Rye is actually still alive and quite active. He's not necessarily treating patients, but
no,
he's
he is.
Is he really?
Yeah, he's treating.
Oh my goodness.
And Dr. Benet is still alive. And,
yes.
Yeah.
But at the conferences, you will see if you ever go to ASH or something like that, Canty Rye is right there questioning the science and seeing what's going on, which I find very fun.
And this is 40 years old, this stuff. Yeah.
Yes,
Yeah.
because this, there's questions about if we should still be using these staging systems. But for right now, this is what we're doing. All right. The difference, really the difference is just in where you're going to be placed, whether or not you need treatment and how, right? So when you're looking at the RISE system, the lymphocytosis is like they're looking at your lymphocyte counts, basically, right? Where is the disease active? You're getting a stage. Obviously, the lower stages are better. You would prefer to be a stage 0 or 1. The higher the number gets, the more your disease is proliferated, or the higher the number of, or the amount of cancer that they see in your system. All right. What they're doing then is looking at your lymphocyte counts, but then also looking around where else the cancer may have spread within the patient. So when they're looking at your spleen or your liver is what they're looking at. Are they seeing CLL cells there? They're looking at, do you have any anemia? Again, it's an indication that your immune system is not functioning, but also that your white blood cells are crowding out the red blood cells, so they're not able to do their work. And then thrombocytopenia is just your platelet count. Doctors like to use really big words for things that are quite easy to talk about. So if you have questions, that's what they're looking at in the American system, right? So that RISE staging system is just those counts. When we look at the Benet system, they're looking at the same things. It's just they're looking at it a little bit differently and how they term it, right? So one, instead of a 0 to 5 scale like they use with Rye, it's an ABC because Benet decided that was a better way to classify things. The HB and the platelets, again, they're looking at your red blood cells, your hemoglobin, and your platelets compared to where they see the cancer cells functioning in your body. And as those progress, as they see more of those other things, is when they're deciding that you have a bigger bulk of disease in your system. These are very different than you're going to see in traditional lymphoma, right? So lymphomas, you usually see some more definition of lymph node growth because it's all happening in the lymphatic system. So it's a very different grading system when you're looking at CLL that's happening within the blood. All right? But really all you need to know is even if these things are happening, it does not need, and you have a patient has is diagnosed at a higher stage of the disease, it does not necessarily mean that they're going to get treated right away. All right? Those things are not equal. CLL is still really treated in most cases, though there is some research coming out that points things a little bit differently, based on symptoms. So it's how the patient is coping, what's their quality of life, or how are they functioning overall. That's what's more is going to trigger first treatment rather than a lymphocyte count, right? All right, good. Now I'm going to pass it to Michael.